Hi everyone, my name's Shauna Brandon. I'm a new grad nurse practitioner and I'm going to talk to you today about red eyes in primary care. This is another issue that you'll see quite frequently in the clinic, so let's get started. Let's begin by looking at the anatomy of the eye. I don't know about you, but I've always been intimidated by the eye, so we'll go through this together and hopefully it clarifies any questions that people may have about the structure of the eye. So when you look directly at the eye, you can see that it's composed of a white area here, which is the sclera of the eye. The pigmented area here is the iris, and that is involved in regulating the pupil size. The pupil is the dark center area where the light actually enters the eye. The iris is regulated by the sympathetic and parasympathetic nervous system and is involved in constriction via sphincter muscle and dilation via dilatory muscles. Another way to think of the eye is through the layers of the eye. So if you look down below, you can see that the eyeball itself is actually composed of 3 layers. The outermost layer is the sclera of the eye, and it also includes the cornea, which is this area right here. The cornea is a transparent membrane that allows light to pass through it to the retina, and it contributes to the refraction of light and the focus of vision. It's avascular, so all of its nutrients comes from diffusion from local blood vessels in the sclera as well as aqueous humor. In addition, the corneal epithelium is heavily innervated by sensory neurons, which means that any injury to the epithelial layer can result in a foreign body sensation, a burning sensation, or occasionally very significant pain. The next layer of the eye consists of the uveal tract. That is this pink area here, and that is composed of the iris, the ciliary bodies, and the choroid. The choroid is a deeply pigmented layer of tissue that prevents light from scattering once it's entered the eye. The last layer is the retina, and that's the neural layer of the eye. It's composed of cones and rods, as well as the macula, which is involved with sharp, detailed perception of vision, and the optic disc, which is the blind spot of the eye and is the location of the optic nerve, also known as cranial nerve number 2, innervation, as well as the insertion point for optic vasculature. Another way to look at the eye is by considering the chambers of the eye. So there are 3 chambers of the eye: the anterior chamber, which is here and is composed of the space between the iris and the cornea's innermost surface or endothelial layer, and it is filled with an aqueous fluid known as the aqueous humor. The second chamber of the eye is the posterior chamber. It is the area between the iris and the lens of the eye. It is also filled with aqueous fluid, and the aqueous fluid is created in the capillary beds of the ciliary bodies. It moves out through the posterior and anterior chamber, flushing these areas and then eventually draining through the canal of Schlemm, which is also known as the scleral venous sinus. The lens of the eye is involved in acute vision changes and allowing for focus on near and far objects. It is held in place by the ciliary bodies as well as these small ligaments known as zonules, and constriction of the ciliary body results in changes in the curvature of the lens, thus allowing the eye to focus on near and distant objects. The last chamber of the eye is the vitreous chamber. That's this area back here. It is filled with vitreous fluid, which is a thick gel-like fluid that pushes outward within the globe of the eye to help maintain that spherical structure of the eyeball. The last area of the eye that I'd like to talk about is the conjunctiva layer of the eye. So up in the top corner you can see here the eyelid, the upper and lower eyelid, as well as the eyeball. The conjunctiva is the area of the eye that becomes irritated in people who have conjunctivitis. It's a thin, transparent layer of vascular mucous membrane that lines the posterior surface of the eyelid, and that area is known as the palpebral conjunctiva. It then folds back on itself to cover the anterior surface of the optic globe, and this area is then known as the bulbar conjunctiva. Okay, so now that we've survived this nightmare that is the structure of the eye, let's move on to history taking. When someone comes in and they're reporting a red eye, you want to make sure you find out the onset and duration of the redness, exposure to any sick contacts, history of allergies or atopic triad, so that's the asthma, atopic dermatitis, and allergies, any new or shared eye cosmetics, soaps, or lotions that could cause irritation to the eye. Vision changes are important to ask about as they could indicate a more sinister underlying diagnosis. Ask about any itchy or scratchy sensation, whether pain is present, any discharge. Find out whether that discharge is watery or purulent. Photophobia is another important question to ask. Photophobia could indicate as well a more sinister underlying diagnosis. Ask about any history of injury or trauma, contact lens usage, and any previous history of eye disease. Next, moving on to the physical examination, you want to look at both pupils, find out whether they are appropriately sized and equivalent, whether they're reactive to light, noting whether they are sluggish in constriction at all. Also, you want to assess for any discharge. You want to look at the color and the consistency, as well as whether there's debris present in the eyelashes. So you can see in the top corner, let me get my pointer, up here, there is some yellowy, purulent looking discharge that's crusted around the eyelashes. You also want to inspect the lids for edema, any vesicles, or allergic shiners. Here's a picture of an allergic shiner, and it looks like bruising around the eye is associated with chronic allergies. You also want to inspect for photophobia. As I mentioned, that could be a more sinister finding, as well as visual acuity, so that would be with the Snellen eye chart, for example. You also want to assess extraocular movement. Note whether there are any lesions or swelling in the periorbital tissue. Invert the eyelids to look for any foreign bodies or cobblestoning of the eyelids. You also want to check for globe tenderness, and that can be done by having the patient close their eyes and you gently pressing against the eyelids with a finger. And you also want to look for lymphadenopathy. As always, you want to identify any potential red flags. That can include things like a sudden severe pain that may be associated with vomiting or colored halos around light, such as in angle closure glaucoma. And you can see in this picture here, there's a difference in the size of the pupils as well as significant redness to the scleral layer of the eye. You also want to look at things like zoster skin rash, decreased visual acuity as mentioned before, corneal ulceration. In this picture below, you can see the yellowy area here that indicates a corneal ulceration. You want to be particularly conscientious of the risks that contact lens wearers have of increased risk of corneal ulceration. You also want to look for things like irregular pupils, sluggish pupils, branching dendritic corneal lesions that could suggest a herpes simplex infection, an ocular pressure of greater than 40 millimeters of mercury. The normal pressure in the eye is between 12 and 22 millimeters of mercury, so obviously 40 is a significant increase in pressure of the eye. Also consider ocular tenderness. That may indicate an iritis, scleritis, or glaucoma. And if pain is not relieved by a test dose of a topical anesthetic drop, then that is another red flag. So things like significant pain or pain that's not relieved by a topical anesthetic drop, photophobia, or decreased visual acuity all require a referral to ophthalmology. I don't know about you, but I am not an expert in eyes, so when I see someone with any of these symptoms, I want to make sure that they're getting the help that they need. Conjunctivitis is one of the most commonly seen forms of eye disease in primary care. It's colloquially known as pink eye, and it results from the inflammation of the conjunctiva. The severity of conjunctivitis can vary significantly, from a mild hyperemia with some tearing to a significant conjunctivitis with purulent drainage to the point where eyelids can be sort of glued shut due to the significant volume of drainage that's present. Diagnosis is usually based on history and physical examination, although microscopic and culture studies may be required to identify the cause. The causes of conjunctivitis can either be infectious, such as bacterial, viral, chlamydial, fungal, or parasitic, or non-infectious, and that can include things like allergic causes, toxins such as irritants, dust, smoke, and irradiation, or secondary to another disease such as Kawasaki disease. Some basic patient education to provide to patients who come in with conjunctivitis include things like reassuring patients that most causes of red eyes are self-limiting, avoid contact lens use until the problem resolves, avoid any irritants such as makeup, smoke, or wind that could cause additional irritation to the conjunctiva, perform lid hygiene by cleansing the affected area with a single tissue or cotton ball and wiping from the inner canthus outward. You also want to encourage patients to avoid using ophthalmic vasoconstrictors more than 3 times a month or for more than 3 days in a row, as this can result in a rebound hyperemia. And some patients may also have a reaction to preservatives found in artificial tears. So if a patient does require artificial tears, you want to encourage them to use one without preservatives if they find that that is an irritation for their eyes. Let's look a little more closely at the various causes of conjunctivitis. So bacterial conjunctivitis accounts for up to 50% of cases of conjunctivitis, with Staph aureus, Strep pneumo, H. flu, and M. catarrhalis being the main culprits. Bacterial infections are more common in children and they're highly contagious, so you want to restrict contact with others for 48 hours after treatment is initiated to help prevent the spread of the bacteria. Signs and symptoms include a rapid onset of an acute unilateral or bilateral conjunctivitis. There's usually a significant amount of discharge that can be gluey and stick to the eyelids, with crusting of the eyelashes noted, especially first thing in the morning. Patients may report that they had to soak their eyelid with a warm cloth before they were able to open their eye, for example. There may be discomfort or a foreign body sensation present as well. And the treatment is usually, it's a self-limiting issue most of the time. However, topical antibiotics are associated with a significantly improved rate of early remission. So you can go with either polysporin or optimicin drops or ointments. However, if the patient uses contact lenses or there's corneal involvement or treatment failure, then you need to go to a stronger antibiotic such as a fluoroquinolone. If there's no improvement within 24 to 72 hours, then you want to refer off to a specialist. As well, if there's moderate or severe ocular pain, severe purulent discharge, or diminished visual acuity, or if the conjunctivitis is related to a sexually transmitted infection, then you definitely want to refer to ophthalmology. And as well, photophobia is a sign of corneal involvement, so that requires a referral as well. Viral conjunctivitis is more common in adults and is usually due to adenovirus, Coxsackie virus, or echovirus. It's often associated with a recent contact or recent cold or flu-like symptoms. It's usually a self-limiting issue resolving by 12 days. In comparison to bacterial conjunctivitis, viral conjunctivitis usually presents with a thin, clear, watery discharge, minimal lash crusting, and a rapid onset of unilateral or bilateral diffuse conjunctival redness. There may be itching of the eyes or a history of conjunctivitis. Systemic symptoms may include things like sneezing and rhinorrhea, and palpable and tender preauricular lymph nodes may be present. You don't need to treat this unless you suspect that it's herpes keratitis, in which case you'll refer on to ophthalmology. For symptom management, patients can try cool compresses or topical lubrication, and you want to encourage good hand and eye hygiene. Allergic conjunctivitis is often a seasonal issue, and it's usually found in people who have other atopic conditions such as seasonal allergies, eczema, asthma, or urticaria. There's bilateral involvement, ocular itching, and watery or mucoid discharge. And that discharge may present as a thin, white, ropey discharge. Eyelids may be red or edematous, and you want to look under the eyelids to see whether there's cobblestoning present on the superior palpebral conjunctiva, and whether there's any corneal ulcerations or keratitis present. Treatment for allergic conjunctivitis involves use of cool compresses, antihistamines, and mast cell stabilizers. Chlamydial conjunctivitis is an ophthalmologic emergency, and that's due to the risk of corneal perforation associated with the disease. It has an incubation period of about 1 to 2 weeks, and women tend to be more susceptible than men. It's also the most common cause of ophthalmia neonatorium, which we will discuss in the next slide. Signs and symptoms of chlamydial conjunctivitis include a unilateral or occasionally bilateral conjunctivitis with a mucopurulent discharge, marked hyperemia, papillary hypertrophy, and predominant follicular conjunctivitis. Preauricular lymphadenopathy is also quite common, and it's important that these patients be referred to ophthalmology in order to prevent any long-term sequelae. Ophthalmia neonatorium refers to a conjunctivitis that occurs within the first month of life. It's most commonly related to a chlamydial infection, and that usually presents by day 3 to 5 of life. Other causes include toxins such as silver nitrate or erythromycin, and other infectious causes include gonorrhea and HSV. Neonatal chlamydia infections are associated with ocular congestion, edema, and discharge that tends to be more watery in nature and develops a few days after birth, and then usually lasts for 1 to 2 weeks or longer. Gonococcal infection is the most serious sight-threatening infection, and that's related to the rapid penetration of corneal epithelium causing corneal ulceration. Neonatal gonococcal infection is also associated with marked bilateral purulent discharge and local inflammation. This requires systemic antibiotics and possible hospitalization. So for the sake of nurse practitioners working in primary care, these patients need to be referred to a specialist. So now moving away from conjunctivitis to other causes of red eye, let's look at dry eye or keratoconjunctivitis sicca. This can either be due to a lacrimation problem or excessive evaporation of the aqueous layer of the eye. Causes of the lacrimal pathology of dry eye include things like Sjögren's syndrome, idiopathic age-related disease, lacrimal gland scarring, facial nerve palsy, and certain medications such as anticholinergics, antihistamines, diuretics, and beta blockers. If the dry eye is the result of excessive evaporation of the aqueous layer, that can be due to things like posterior blepharitis, a vitamin A deficiency, eyelid abnormalities, preserved topical ocular medications, contact lens use, and allergic conjunctivitis. Signs and symptoms include things like dry, red eyes, having a foreign body sensation, blurred vision, and tearing. If you're concerned that complications such as erosion or scarring of the cornea has occurred, then you can consider fluorescence or rose bangle staining to assess for surface damage. Treatment for dry eyes includes the use of preservative-free artificial tears and an ointment at bedtime. Ointments tend to be quite thick and sticky, so people generally prefer to use them at bedtime when their eyes are closed for sleep. If it's very severe, then you can consider a cyclosporin ophthalmic emulsion. And whenever possible, you want to treat the underlying cause of the dry eye. Subconjunctival hemorrhaging occurs when there is bleeding between the conjunctiva and the scleral layers of the eyes. It's an otherwise asymptomatic issue and can be idiopathic or associated with trauma, Valsalva maneuver, or a bleeding disorder. People who are on anticoagulants, as well as those who have hypertension or diabetes, are more susceptible to subconjunctival hemorrhages, and there's usually an absence of lacrimation, itching, or photophobia associated with this. Generally, it resolves spontaneously in 2 to 3 weeks as the blood is cleared away, And if it becomes a recurrent issue, then it's important to consider a hematologic workup. As well, if the hemorrhaging is extensive or if it interferes with proper eyelid closure or does not resolve within a few weeks, then it's important to refer these patients to ophthalmology for less common causes of conjunctival hemorrhaging, which include things like Kaposi sarcoma. Angle closure glaucoma is another ophthalmologic emergency. It accounts for 5% of all glaucoma cases, and it's resulting from the inability of the aqueous humor to drain through the canal of Schlemm. So as discussed in the anatomy of the eye, the aqueous humor is produced by the capillaries of the ciliary body. It then washes over the posterior and anterior chamber of the eye and drains through the canal of Schlemm. If there is a blockage in that canal, then the aqueous fluid just continues to build up and increase the intraocular pressure. Risk factors for angle closure glaucoma include things like hyperopia, which is a small eye with a big lens, a family history, age over 70, female gender, Asian or Inuit descent, pupillary dilation from certain medications such as topical decongestants or vasoconstrictors, as well as pupillary dilation from stress or darkness. So for example, patients who are in a dark area for a long period of time, such as watching a movie, and then exit into the very bright midday sun may be at an increased risk for angle closure glaucoma. Usually this presents with a dramatic pain and blurred vision that has a sudden onset. The pupil is fixed and mid-dilated. Usually it's a unilateral issue, but the other eye is at an increased risk. They may report halos around light, nausea, vomiting, or abdominal pain, and there's that increased intraocular pressure which I mentioned, and that is such a marked increase in the intraocular pressure that it's noticeable even with palpation. So if you press gently on the eye, you'll feel that the eye is much firmer than the other eye. Physical examination will reveal conjunctival hyperemia, corneal cloudiness, and papillary dilation with a sluggish or absent response to light. This is an ophthalmologic emergency because it can result in loss of vision within hours to days if it's not treated. Corneal abrasions and trauma are the result of a mechanical damage to the corneal epithelium. It often results in response to contact lens use, which can deprive the cornea of oxygen, and it makes these individuals more at a higher risk for Pseudomonas infection as well. Signs and symptoms include things like pain, redness, tearing, photophobia, and a foreign body feeling. Pain is usually relieved with a topical anesthetic. As well, complications for corneal abrasions include things like infection, ulceration, recurrent erosion, and secondary iritis. Treatment involves topical antibiotics and analgesics. Most abrasions clear spontaneously within 24 to 48 hours. And patching is no longer indicated. That previously was something that anyone who had a corneal abrasion, it was recommended that patching be done to their eye, but now if the abrasion is less than 10 millimeters, no patching is required, as it doesn't improve the healing rates or report of pain. Keratitis refers to inflammation of the cornea, and it can be due to an infection, hypersensitivity reaction, ischemia, or defective tear production, as well as an interruption in the sensory innervation. It's divided into two subtypes, so non-ulcerative, which occurs when all layers of the epithelium are affected, but the epithelium remains intact. It's associated with viral infections, syphilis, tuberculosis, and lupus, and the treatment is symptomatic at that point. The other subdivision of keratitis is ulcerative keratitis, which occurs when parts of the epithelium, stroma, or both are destroyed. It's caused by infectious agents, such as those that cause conjunctivitis, trauma, extended contact lens use as well, and the treatment is based on the underlying cause in those cases. Uveitis refers to inflammation of one or more parts of the uveal tract, which, if you recall back to the anatomy slide, includes the iris, the ciliary body, and the choroid. It can be idiopathic or associated with an autoimmune, infectious, granulomatous, or malignant cause. It is another issue that should be referred on to ophthalmology for specialized treatment. Anterior uveitis, which is also known as iritis, refers to inflammation of the iris, and it's usually a unilateral issue that presents with ciliary flush, which you can see down below here. Scleritis, which is the inflammation of the sclera, episcleras, or conjunctival vessels, may be present as a manifestation of a systemic disease, such as collagen vascular diseases, granulomatous, such as the case of tuberculosis and sarcoidosis and syphilis, metabolic, as seen in gout and thyroid toxicosis, infective, or related to chemical or physical agents such as thermal or acid burns. Signs and symptoms are severe pain, photophobia, red eye, and decreased vision. It's usually a bilateral issue. Anterior scleritis involves pain that radiates to the face and may cause scleral thinning, whereas posterior scleritis is rapidly progressive towards blindness and may cause exudative retinal detachment. Either way, it's an ophthalmic emergency that requires a referral. It's more common in women and the elderly. Next, we'll look at herpes simplex keratitis, which is the most common cause of corneal ulceration. It's usually due to an HSV-1 infection, except in neonates, in which case it's more commonly an HSV-2 infection. It can be triggered by stress, fever, sun exposure, or immunosuppression. Signs and symptoms include pain, tearing, foreign body sensation, red eye, decreased vision, and eyelid edema. And when you look at the eye under fluorescent staining, you can see dendritic lesions of the epithelium. So let me just get my pointer. And here you'll see those dendritic lesions that I mentioned. Complications associated with herpes simplex keratitis include corneal scarring, which can lead to vision loss, chronic interstitial keratitis, secondary iritis, and secondary glaucoma. Treatment is with a topical antiviral, and consider an oral antiviral agent, as well as dendritic debridement. Again, this is a referral to ophthalmology, and you want to at all costs avoid steroids in these patients, as this may exacerbate the condition. And the last cause of red eye that we're going to talk about today is herpes zoster ophthalmicus. This represents approximately 10% of all cases of herpes zoster and involves the reactivation of the zoster virus on cranial nerve number 5. It's more common in people who are immunocompromised, and Hutchinson's sign is something to consider when you are considering whether herpes zoster ophthalmicus may be an issue. So that refers to whether the tip of the nose is involved, and if it is, then the risk of eye involvement goes up to about 75%. If there's no nasal involvement, then risks of the eye becoming involved is only about 1/3. Signs and symptoms of herpes zoster ophthalmicus include pain, tearing, photophobia, red eye, corneal edema, pseudodendritis, and corneal hypoesthesia. Complications include corneal keratitis, secondary iritis, secondary glaucoma, cataracts, and postherpetic neuralgia. Again, this requires a referral to ophthalmology, and these patients need to be treated with oral antiviral immediately. So that is it for red eyes in primary care. Please let me know if you have any questions or comments in the comment section below. Thank you.